Ready? Thank you very much. This is Cardiac Sciences Grant Rouse. I don't need to introduce Professor Mitchell. Everybody knows him. If you haven't, if you don't know him, you've probably been hibernating somewhere. So Dr. Mitchell already gave us part one of the review of the Canadian Cardiovascular Society upgrade on the update on the AF guidelines, and he's going to take on part two. So with no further ado, Mitch.
All right, I will begin to share my screen. To do that, I want to hit this guy. Is that sharing?
Not yet. Sometimes it takes a second or two. There you go.
Yeah.
Go to presentation mode and we're all set to go.
All right. Yeah. So as you have just heard, and thank you for the kind introduction, we're going to go on today and do part two of the guidelines. I noticed that the Canadian Cardiovascular Society is putting on a series of seminars on their recently released guidelines. They expect that it will take them, what would the total would be, 4.5 hours to go over the guidelines. We're trying to do it in 2, so we better get moving. Biggest problem I'm having right now is, okay. So the guidelines that we're talking about were those that were created by the Canadian Cardiovascular Society and the Canadian Heart Rhythm Society. Many of you will be aware that the CCS has a group of disorders for which their guidelines have been created and are updated on an annual basis. And then every 10 years, there is a comprehensive review and a rewriting of all of the guidelines under that title. So last year was the Atrial Fibrillation Guidelines Committee's turn to do its 10-year update. The guidelines were first presented at the Canadian Cardiovascular Society Congress, or Canadian Cardiology Congress, last fall, and were simultaneously published in the Canadian Journal of Cardiology. By the numbers, there are 11 chapters, 101 pages, 885 references, and 129 recommendations. So it's a very large undertaking, but not as voluminous nor as expensive as the Canadian budget that was released yesterday. Time will tell which of these two exercises was more valuable. As always, I'll begin with my disclosures. You may have already inferred that my politics are conservative, but my other potential biases are listed here. Of greatest importance are the relationships with manufacturers of novel or direct-acting oral anticoagulants. I am also a member, of course, of the Atrial Fibrillation Guidelines Committee. So today I'm going to try not to spend too much time just reading to you guidelines, but rather focus on the central figures of the document, which summarize many guidelines at a time. In part one, we focused on oral anticoagulation therapy in patients with atrial fibrillation. Today, I'm going to focus on management of the arrhythmia itself in atrial fibrillation patients. If time permits, I will address a question that was raised after last time's presentation regarding anticoagulation. But on the other hand, if time does not permit, I won't do so. So, management of the arrhythmia. Because the approach to rate and rhythm control in the acute setting really does depend on long-term goals, I'm going to start a little backwards today and begin the presentation with considerations of chronic rate and rhythm control. So We'll come back to the hemodynamically unstable patient, and we'll come back to the emergency room approach to the rhythm disturbance itself, but begin with hemodynamically stable, acute, chronic, or recurrent atrial fibrillation. Now, we always talk about how there's a choice to be made between rhythm control and rate control, a shared decision-making process. But in truth, everybody needs rate control, or except for the odd patient who is auto-controlled their ventricular response rate. So the real question is, do we do rhythm control or do we not do rhythm control? But let's first dispense with long-term rate control. There's nothing new here at all. Jason Andrade made all of these figures, and I think he must have conservative leanings too, because all of his figures read best starting from the right. On the other hand, though, Jason lives in British Columbia, so whether or not he's conservative is a matter of secrecy, I'm sure. Long-term rate control, the first guideline that was created is the goal for rate control is a resting ventricular response rate less than 100 beats per minute. So if that is not achieved by the patient themselves, then patients are divided into those who have been demonstrated to have, or those who are suspicious to have, relative preservation of left ventricular ejection fraction versus not so. So if in those patients with relative preservation of left ventricular ejection fraction, one can use a beta blocker for long-term rate control or a non-dihydropyridine calcium channel blocker. The guidelines don't distinguish a preference between the two, but most of us who do this a lot start with the calcium channel blockers because beta blockers have actually been demonstrated to reduce exercise tolerance and, of course, are associated with more side effects than are the non-dihydropyridine calcium channel blockers, especially in young patients. When such therapy is insufficient, the other is added, so a non-dihydropyridine calcium channel blocker to a beta blocker, or a beta blocker to a calcium channel blocker, and if necessary, digoxin is added for triple therapy. On the other side of the ledger, those individuals with depressed left ventricular, significantly depressed left ventricular ejection fraction or systolic function, these individuals already need to be on a beta blocker, so beta blocker is the obvious choice. And of course, the non-dihydropyridine calcium channel blockers are not the best kind of therapy for individuals with systolic left ventricular dysfunction. If necessary, digoxin is added. And if all of those approaches lead to a resting heart rate of less than 100 beats per minute, then rate control has largely been achieved. Now, we do see the odd patient in whom resting rates are controlled, but exercise rates are not. That requires more assertive therapy. The red box at the bottom reminds us that one mechanism of achieving rate control is to achieve rhythm control. And if all else fails, of course, there is pacemaker implantation and AV junction ablation, but I'll return to that near the very end. So once rate control has been established, the question is then asked, who gets rhythm control? It used to be simple. There were a lot of trials performed wherein rate control with drugs was compared to rhythm control with drugs, of which, of course, Dr. Wise's AFFIRM trial was one of the best. This is a meta-analysis of all of the trials that were of that ilk. The meta-analysis here, though, to be true, most of the other meta-analysis slides that I'll show today is a little bit different in its display. The forest plot here is not individual studies, but rather individual meta-analyses. For example, in the top line, total mortality in green is a meta-analysis of 10 studies involving 7,867 patients and shows a relative risk for total mortality. The title of the slide is incorrect. It says follow-up ATAFA flood or recurrence. No, not true. Follow-up outcomes. And for total mortality, there was no statistically significant difference between rhythm control and rate control. The same was also true of stroke and TIA, for systemic embolism, for worsening heart failure, and for major bleeding. The only statistically significant difference shown in this meta-analysis was a decrease in the probability of rehospitalization for patients following a rate control approach. And that is, of course, because rhythm control requires interventions that frequently result in rehospitalization. What's shown here is the fact that the only statistically significant advantage of rhythm control over rate control using drugs was an improvement in symptoms. To the extent that atrial fibrillation was bugging the person felt better if they were not having atrial fibrillation. So it was quite simple then. Who gets rhythm control? Individuals in whom long-term therapy is not planned. That is, the first episode of atrial fibrillation. We wait for the second episode before introducing long-term therapy in most people. So rhythm control is established, usually by cardioversion, and the patient is simply followed without additional therapy. Same is true for reversible atrial fibrillation, although some therapy may be required during the time period needed to reverse the underlying cause. But in these two kinds of people, long-term therapy is not planned. So the goal, of course, is to enter that long-term period in sinus rhythm. Thereafter, rhythm control is required when rate control cannot be achieved, or when bothersome symptoms persist despite rate control. I call those people angry face atrial fibrillation patients. I divide people with atrial fibrillation into three groups. Angry face atrial fibrillation patients are those who are willing to be exposed to any risk to prevent their atrial fibrillation because they find it so bothersome. There are also, of course, happy face atrial fibrillation patients who don't even know they're in atrial fibrillation, and therefore we would not expose them to the risk, usually, of rhythm control therapies if there are no symptomatic improvements to be gained. Unfortunately, of course, most people are in between. I call them sad face atrial fibrillation patients. They don't like their atrial fibrillation, but are not sure that they wish to be exposed to a risk in order to prevent episodes of atrial fibrillation. But some patients with angry face atrial fibrillation can even be predicted beforehand. And in those individuals, rhythm control is often used in the beginning. Now that's how it's been for many, many years, and it was nice and simple. However, new data has made it much more complicated. The first of these trials is EAST-AFNET 4. Now, EAST-AFNET 4 took patients early in their atrial fibrillation journey, that is, those whose first atrial fibrillation episode occurred less than 12 months ago, but they are having recurrent or persistent episodes, who were at high risk. At high risk because they were older than 75 years, had previous TIA or stroke, or risk factors for stroke events, which was the primary secondary outcome in this trial. Like all of these kinds of trials, it's an unblinded open label trial wherein randomization was used to direct therapy. This was a rate control versus rhythm control study, mostly with drugs. So it's very akin to AFFIRM, but focused on those patients who have just begun their atrial fibrillation journey. Ablation was permitted in this trial, but it was used very sparingly, less than 10% at the outset and less than 20% by the end of the trial. The primary outcome was the composite vascular death, stroke or heart failure hospitalization, or acute coronary syndrome hospitalization. Shown here on the left is the primary outcome in a Kaplan-Meier format, and we can see that early rhythm control had an advantage over usual care. The hazard ratio for the primary outcome of cardiovascular death, stroke, or hospitalization for heart failure or acute coronary syndrome was such that over 20% of such instances were prevented, and the difference was statistically significantly different. On the right side are shown individual components of that outcome. You can see that cardiovascular death was reduced, statistically significantly so, by 28%. Stroke was reduced, statistically significantly so, by 35%. Hospitalization was reduced, but not statistically significantly so. And there seemed to be a cost to pay in that serious adverse events related to the medications or ablation used to treat the underlying rhythm disturbance was more frequent in the ablation arm. This question was also asked in a slightly different way by Jason Andrade, who performed a trial called Early AF. Again, these are individuals with atrial fibrillation that has been present or recurrent for less than 1 year. In this study, patients were randomized to rhythm control with drugs versus rhythm control with ablation. So it's not quite like the previous study, but rather it's a comparison of two different modes of rhythm control, having already reached the conclusion by virtue of AFNet East that there was an advantage to be gained by rhythm control. The results of this trial are shown here. The primary outcome in this much smaller trial was the recurrence of an atrial tachydysrhythmia. And we can see that more than half of such events were prevented with ablation therapy in comparison to medical therapy. Individual outcome events are shown on the right. Symptomatic atrial tachydysrhythmia recurrence was reduced by 61% using ablation compared to medical therapy. The AF burden was markedly reduced. And in this trial, serious adverse events, comparing now ablation to type or class 1 or 3 antiarrhythmic drugs, were very comparable. This trial was also performed much more recently, when the adverse event rate of ablation procedures has fallen. There was a reduction in hospitalization with ablation therapy, but in this instance, in a relatively small trial, did not reach a statistically significant difference. So, who gets rhythm control? Those with early atrial fibrillation are now considered appropriate for primary rhythm control, especially by ablation. Those last two trials that we discussed are focused on early AF. Let's return now to the broader group of patients with non-early atrial fibrillation. This is a meta-analysis of ablation versus drug therapy of whatever variety in patients with atrial fibrillation. Shown here is the primary outcome of which works better for the prevention of atrial tachydysrhythmia recurrences. That is true, as shown in the green, in all patients in 18 studies. In heart failure patients, shown in magenta, in 7 studies. In patients without heart failure, shown in orange, in 13 studies, versus true antiarrhythmic drugs, class 1 or 3, in 10 studies, shown in blue, versus rate-controlled drugs, no great surprise, in 3 trials, in persistent atrial fibrillation in 7 trials, and in paroxysmal atrial fibrillation in 6 trials. So there's essentially no doubt whatsoever that ablation prevents tachydysrhythmia recurrences better than do class 1 or class 3 antiarrhythmic drugs. More importantly, though, these are other follow-up events. In all patients, shown in the top green, for the outcome of all-cause death in 9 studies involving 3,500 patients, there is a statistically significant reduction in all-cause mortality. All of these trials being randomized controlled clinical trials. With a reduction in mortality that is substantial, 31%. Most of that reduction appears to be in patients with congestive heart failure, shown in magenta, as opposed to patients without congestive heart failure, shown in the orange. With respect to the outcome of stroke, though, in all comers, not just early atrial fibrillation patients, there is a signal for a reduction in stroke, but it is not statistically significantly different. And all-cause badness seems to be reduced in patients under the age of 65 compared to patients over the age of 65. All-cause badness, I have to read to you, consisted of the composite of death, stroke, major bleed, cardiac hospitalization, or cardiac arrest. But a signal, you'll agree, that maybe patients with heart failure and maybe patients who are young might be advantaged by an ablation approach to their underlying rhythm disturbance. This was addressed with respect to heart failure patients directly in CASTLE-AF, patients with atrial fibrillation who were symptomatic with their heart failure despite optimal medical therapy, with a documented left ventricular ejection fraction less than 35%, who were eligible for either catheter ablation or medical therapy, and who had an atrial monitor, that is an implanted DDD ICD. Remember, they have left ventricular ejection fractions under 35%, who also received oral anticoagulant drugs, were randomly assigned to whatever drug you wanted to use for rhythm and/or rate control versus catheter ablation. So the CASTLE-AF study is a catheter ablation versus anything else that you might want to do study. The primary outcome variable was the composite of death or heart failure hospitalization, shown on the left, and there was a 38% reduction in the probability of this outcome over 5 years using ablation compared to medical therapy. One of the primary secondary outcomes was all-cause mortality, a reduction of 47%. And another primary secondary outcome variable, heart failure hospitalization, a reduction of, do the math, 44%. So very, very significant outcomes that kind of shook the community to its core. But the CASTLE-AF trial is not the only trial of this sort. This is a meta-analysis of CASTLE-AF and other such studies, showing on the left that mortality is halved by ablation compared to medical therapy in such patients, as is heart failure hospitalization. Shown on the right, other less mortal outcomes, rhythm control performed better with the Minnesota Living with Heart Failure questionnaire quality of life assessment tool in terms of improvement in left ventricular ejection fraction and in terms of improvement in 6-minute walk test. Yes, I do know that the Minnesota Living with Heart Failure questionnaire shows improvement by decreasing, but that made the slide look really stupid. So you'll see that it's the absolute value of the changes in units, so I can make the slide look better. So you've seen this slide before. I've just added the very bottom bit of the forest plot. This is pharmacologic rate control versus pharmacologic rhythm control in atrial fibrillation. In that meta-analysis performed as far back as 2013, there was also a signal that maybe the young, shown at the very bottom in orange, might be advantaged by a rhythm control approach. Already reviewed the fact that one meta-analysis suggested that that might be true, even comparing ablation to drugs. So let's end this discussion. Who gets rhythm control? The bottom two, or I guess the bottom three, are the new ones. Early atrial fibrillation, patients with left ventricular systolic dysfunction, and maybe the young. Now, the young have not yet had a study of their own, hence the question mark, and there actually isn't a guideline specific to the young in the current guidelines as yet. Now, this causes us a great deal of grief in Calgary. For the waiting list for atrial fibrillation ablation is over a year, which means we can't provide guideline-directed therapy for patients with early atrial fibrillation, or by the time they have their atrial fibrillation ablation, they no longer have early atrial fibrillation. It's been more than a year. That is the most self-serving comment that I hope I make today. So, the actual wording of the relevant recommendations: we recommend a rhythm control strategy for patients with established atrial fibrillation who remain symptomatic, with rate control therapy, or in whom rate control therapy is unlikely to control symptoms. Strong recommendation, moderate quality evidence. We suggest consideration be given to rhythm control rather than rate control for patients with newly diagnosed atrial fibrillation, a weak recommendation with moderate quality evidence. Way down to the bottom, practical tip: in selected cases, ablation might be preferred as first-line therapy. The previous iteration of the guidelines said that this would be rare. It appears that it's going to be appropriate with greater and greater frequency. Not too much other than catheter ablation has happened in terms of long-term rhythm control. Again, if we start Jason's chart on the right, in those individuals with no heart failure and no coronary artery disease, the 5 drugs that are available for this purpose are listed in alphabetical order. Of course, we usually begin in the bottom and work up. In patients with coronary artery disease, flecainide and propafenone, being 1C agents, have been demonstrated to increase the probability of death, so they're not on the list anymore. In individuals with heart failure, sotalol is permitted if the left ventricular ejection fraction is relatively preserved, but you're limited to amiodarone or to catheter ablation in individuals with significant reduction in left ventricular ejection fraction. And we've just seen some evidence that the red may now be better than the green. Just a few words about AV junction ablation. What is it? It's transvenous catheter ablation of the compact AV node or of the His bundle. We prefer the former. If you ablate the compact AV node, the resultant escape rhythm is about 42 beats per minute. See the Hitchhiker's Guide to the Galaxy for the importance of that number. Whereas if you ablate the His bundle, you usually end up with a slower ventricular response rate, which may not even be existent. Right-sided approaches are usually used, but occasionally a left-sided approach is required. And the goal, of course, is to produce purposeful AV block after the insertion of a right ventricular or bi-V pacemaker to maintain the ventricular rate. Its advantages are the procedure success rate is very, very high, 98%, with rate control and regularization of rhythm. The most important advantage, though, is that it allows discontinuation of negative dromotropic drugs like beta blockers, centrally acting calcium antagonists, and often the ability to do that makes the patient feel the best because they were experiencing side effects from those therapies. There's a demonstrable associated improvement in quality of life, and in patients with left ventricular systolic dysfunction, there's a small improvement in the left ventricular ejection fraction that is likely due to the component of the reduction in left ventricular ejection fraction that was the result of a tachycardia cardiomyopathy. The disadvantages: there's about a 1% serious procedural complication rate. Nevertheless, it is the safest procedure ablation that we do. And there's about a 3% probability that the procedure will have to be done twice because of recurrence of conduction. It produces an absolute in about 5% or a relative in the other 95% dependence on their pacemaker function. It exposes the patient to all of the complications of pacemakers. But in particular, there's a small, about a 0.5% risk of torsade de pointe, ventricular tachycardia after the relative bradycardia induced by purposeful AV block. So all such patients are paced at 70 beats per minute for a month or so in order to allow their electrophysiology to accommodate a slower heart rate. And in some patients, there is a worsening of heart failure due to forced right ventricular pacing. Such patients then require a revision to cardiac resynchronization therapy pacing. There's no change, of course, in anticoagulation requirements. The biggest shortcoming of the procedure is that it is irreversible. Accordingly, it's usually left for last, so thank God it usually works. The specific recommendations with respect to AV junction ablation, one is recommendation number 95 we just talked about. There is another recommendation for AV junction ablation called 97. We suggest AV junction ablation in heart failure patients with AF who are cardiac resynchronization therapy non-responders with biventricular pacing rates less than 95%. So what's that saying is that we know that biventricular pacing doesn't help heart failure patients unless 95% or more of the QRS complexes are created by biventricular pacing. So in patients with atrial fibrillation and a more rapid ventricular response rate where more than 5% of the ventricular responses are created by conduction of atrial fibrillation, CRT doesn't work. And one way, therefore, to get CRT to work would be to produce purposeful AV block. So let us now consider the patient presenting to the acute care sector. If they're hemodynamically unstable, of course, there's a need for an urgent DC cardioversion. If they're hemodynamically stable, we have to decide between rate control, essentially always required. More importantly, we have to decide if acute rhythm control will be provided. And whether or not that will be provided is largely based on the considerations as to whether or not this is the patient's first episode, whether or not the patient is expected to be able to tolerate atrial fibrillation with rate control, and whether or not there is another indication for rate control overall, as we've already discussed. If so, then acute rhythm control is required. The white box under the green one saying acute rhythm control, we talked about last time, and that is in whom can we do acute cardioversion in the absence of preceding oral anticoagulant therapy. They're listed there. We talked about them last time. One can then initiate oral anticoagulation where necessary. And well, actually, as we discussed last time, that's essentially everybody now. And initiate rate control and, if possible, proceed with direct cardioversion if that's where we want to end up. Cardioversion can be accomplished, of course, with DC energy or with drugs, and I'll return to that later. If rate control is chosen, it's the same agents that were discussed before, except one has to be really careful with the combination of acutely, that is intravenously administered beta blocker and intravenously administered non-dihydropyridine calcium channel blocker, or some people will then find themselves wanting blood pressure. So if you're going to use an intravenous agent for the conversion of acute atrial fibrillation, this is a very cool meta-analysis wherein it's a network meta-analysis wherein each of the agents that aren't blue were compared with intravenous flecainide in different studies. So the network meta-analysis can then estimate the relative efficacies of each of the other agencies by virtue of their comparison to flecainide. So acutely administered IV flecainide will terminate acute atrial fibrillation in less than 2 hours in about 2/3 of the patients to whom it is given. Other choices in decreasing efficacy are ibutilide, propafenone, procainamide, sotalol, and amiodarone. Now, vernicalent didn't have a study against flecainide, so it's not on this slide, but we'll return to it in a minute. Now, in the Canadian markets, you can't have intravenous flecainide, you can't have intravenous propafenone, and you can't have intravenous sotalol. So your choices are ibutilide, procainamide, unfortunately spelt wrong, or amiodarone. And I'll talk about at least two of those. Now, everybody's favorites, particularly in the emergency department, seems to be intravenous amiodarone. In that regard, we have to remember that amiodarone's class 2, that is beta blocking, and class 4 calcium antagonist effects are the immediate effects of the drug. Class 1 effects take hours to days to develop, and class 3 effects, that which you really want, take days to weeks to develop. So amiodarone doesn't work very well very quickly. Shown here is that you can't even tell that amiodarone is better than placebo until almost 24 hours. So of course, what all the other intravenous drugs do is compare themselves to amiodarone and make the time limit to conversion something like 2 hours, in which case they will always win. This is a focus on intravenous ibutilide. It's been around a long time, Corvert. The dose is shown there. This is a trial in which ibutilide was compared to placebo in patients in atrial fibrillation or atrial flutter up to 45 days in duration. We can see conversion by 90 minutes is much more likely with active drug than with placebo. And shown on the right is two of the major, shown on the right is the major advantage of this drug, and that is it is remarkably effective in atrial flutter. A little less effective in atrial fib, but in either case, the mean time to conversion is about 20 minutes. The shortest, or the biggest shortcoming of ibutilide, a class 3 agent, is its torsade propensity. It will produce torsade de pointe ventricular tachycardia in around 8 to 9% of patients. So many individuals pre-medicate patients who are about to receive ibutilide with magnesium first. The newest kid on the block is a Canadian drug made by Cardiome, vernicalent, sold under the name Brinavess. It's relatively recent, been released, I think, for about a year. In this trial, patients with acute atrial fibrillation up to 7 days in duration received either intravenous vernicalent in the dose shown there, or placebo, and we can see that these are atrial fibrillation patients. The atrial fibrillation probability with vernicalent was, by 90 minutes, was pretty much 50-50. The median time to conversion is a startling 11 minutes. So this drug is going to gain a lot of traction, in particular in that torsade has not ever been reported to have occurred on the drug. So that was the end of what I wanted to make sure that I did. I think there is time for me to answer one of the questions that came up after part 1's presentation, and that is the special case of subclinical atrial fibrillation, or SCAF. This slide shows very convincingly, by combining aspirin-treated patients in active A and Averroes, that the time spent in atrial fibrillation is an important predictor of the probability of stroke. Patients with permanent atrial fibrillation are statistically significantly more likely to have a stroke than patients in persistent atrial fibrillation, and they themselves are more likely to have a stroke than patients in paroxysmal atrial fibrillation. Indeed, the pattern of atrial fibrillation was the second best predictor of stroke in the future, after the best predictor of all, which is, of course, already had a stroke. The adjusted hazard ratios are shown there. Now, although there's a demonstrable difference in stroke risk. Note that even in paroxysmal atrial fibrillation, the stroke risk is high enough, 2.1% per year, to warrant anticoagulation with the very same recommendations as we give for persistent and for permanent atrial fibrillation. So we make no distinction in that kind of assessment. That is, the AF pattern does not affect recommendations for long-term anticoagulation, but it does raise the question, how low can you go? The shortest episodes of atrial fibrillation that can be found are those found by cardiac implantable electronic devices that have atrial leads. They're called atrial high rate events, shown on the left. The top lead is the atrial lead of a device. The bottom lead is the ventricular lead. In fact, it's ventricular paced. But you can see from the top lead that the patient is in atrial fibrillation. These atrial high rate events, whose name is gradually morphing to subclinical atrial fibrillation, SCAF, are generally asymptomatic, are by definition of short duration, 6 minutes to 24 hours, and are usually infrequent. The primary differential is artifact on the atrial lead, which is what's shown on the right side. The 6-minute floor was selected because our use of a 6-minute floor gives the device a reasonable sensitivity and specificity for diagnosing atrial fibrillation, as opposed to the artifact shown on the right. Now, a whole bunch of trials have looked at the importance of this finding. I like best Jeff Healy's trial called ASSERT, wherein 2,451 patients over the age of 65 with a history of hypertension who received a new pacemaker or ICD with an atrial monitoring, who were not on anticoagulants and did not have prior atrial fibrillation, were followed. And their device was interrogated for the presence or absence of SCAF for the first 3 months. Within 3 months, this kind of patient will have SCAF 10% of the time. 90% of the time, they won't have SCAF within the first 3 months. And then the purpose behind this trial was to assess whether or not the patients with SCAF had outcome events with a different frequency than patients without SCAF. Within 3 months, we saw those two numbers already. Within 2.5 years, though, 36% of patients of this ilk had device-reported subclinical atrial fibrillation. So that's 1 in 3. This is a big population. Whereas clinical atrial fibrillation within 2.5 years had only developed in 5%. So the outcomes divided by SCAF versus no SCAF. SCAF predicts the future occurrence of clinical atrial fibrillation with a hazard ratio of 5.5. SCAF also predicts the occurrence of ischemic stroke with a hazard ratio of about 2.5%, but in this trial didn't predict other important outcomes. So, how big is this risk of stroke? Shown here in the green are the results from SCAF in comparison with clinical AF, the results from the heart meta-analysis performed many years ago, analyzing all of the placebo-controlled trials of atrial fibrillation. So the annual event rate of stroke for all comers in clinical atrial fibrillation approaches 5%. That's a number many of us know and love. This dashed line, the Canadian Cardiovascular Society Guidelines Committee suggested years ago that if the annual risk of stroke exceeds 1.5%, then the risk of anticoagulation is warranted for the purposes of stroke prevention. And we can see that of the kinds of SCAF, no SCAF, 6 minutes to 6 hours of SCAF, 6 hours to 24 hours of SCAF, and greater than 24 hours of SCAF, all of those, or each of those subgroups, only the more than 24 hours reaches the level where anticoagulation might be warranted. Nevertheless, no study has ever been performed in SCAF patients with more than 24 hours of atrial fibrillation. Instead, they're treated just like clinical AF patients. What to do with the other groups is a question that we keep getting in the CIED clinic. This portion of the graph just shows that if you're at higher risk, the numbers go up, but that's no great surprise. So the only recommendation the current guidelines make for SCAF is we suggest that it is reasonable to prescribe oral anticoagulant therapy for patients with atrial fibrillation of the SCAF variety that has lasted more than 24 hours if they would have warranted atrial fibrillation by virtue of their CHAD 65 score in any event. So there is a trial going on right now that I would ask you to send your patients to. It's Artesia, 4,000 patients who have CIED reported SCAF and risk factors are randomly being assigned to apixaban in the usual dose, reduced when it should be, versus aspirin for the primary outcome of stroke or systemic thromboembolism. It's a Jeff Healy and Dr. Lopez trial that is ongoing at the moment. The planned recruitment is 4,000 patients. Sandra Rivest randomized the, what was it, 3,888 patient or something like that on Monday. So there's only 212 patients to go. Within a year, we should have the answer to this important question as to whether or not such patients should be anticoagulated. I thank you for your attention.
Thanks, Mitch. That was a great review. I don't see any questions. So let me ask you something. So for example, Artesia, don't you feel that maybe the patients are not that much at high risk? Because, you know, the only data that we have is that data from the sub-study from the CERT trial, in which we showed that, you know, greater than 24 hours was where there was the greatest risk for stroke. But again, when you look at that data, there's only 58 strokes out of the 2,800 patients. So how do you put that in context into what do you think is going to happen with Artesia? Is it going to be a neutral trial?
Well, with respect to SCAF over 24 hours, it's not even going to answer the question, because if a patient develops 24 hours of SCAF in the trial, then they are exited and anticoagulated. In the trial, you could see what the numbers were. They're all less than 1.5%, which was what the Canadian Cardiovascular Society suggested was required to warrant anticoagulation. So I think it's a 50-50 call. What is important is the trial is almost finished its enrollment, and the DSMB has not stopped the trial. So what we know for sure is there is not any horrible adverse consequence or any massive benefit.
There you go. So that's my point. It's going to be neutral. So it's not going to answer the question.
We'll see. We'll see. They don't stop trials, of course, for small differences.
Of course. So here's a question, you know, if you have a patient that's a CHAD 65 of, so CHAD 65 of 2 is 6 minutes of SCAF, should we anticoagulate them?
No, you should enroll them in a CERT. No, not a CERT.
Artesia.
Artesia.
And if you were in Europe, that would be NOAA, which is the other trial.
Yes, indeed.
Now I used that slide that you showed about Averroes and the differences in rate of stroke based on the type of atrial fibrillation. And, you know, the same trends actually occur with mortality, right?
Yes.
So my point is that, you know, I use that, although there's no proof, I say that if you actually turn someone out from persistent atrial fibrillation and convert him into paroxysmal, maybe you are reducing the risk of stroke, and maybe you are reducing the risk of mortality. And some of the signals that we are getting from particularly patients in heart failure may actually be proving that.
I agree completely that it is, in my mind, crystal clear that atrial fibrillation burden is much more important than the absence versus the presence of atrial fibrillation for 30 seconds once in the last year.
Now, the other point that you raised that was interesting is, the heart failure, LV dysfunction, AFib, younger, whatever young is nowadays, less than 65. But the Cabana AF heart failure sub-study actually didn't show any difference according to age.
Not quite so. In their subgroup analysis, there was a signal of a reduction.
Yeah, no, that was in the general trial, but I mean, in
Yeah.
the trial that was just published, they just published the Cabana heart failure group. And in the Cabana heart failure group, the forest plot of less than 65, 65 to 70, or greater than 70, there's no difference when you have heart failure.
Okay, I'm sorry. I didn't realize you were talking about just the heart failure group. Overall, there was a signal in Cabana for a reduction in the young. But in the heart failure group, by definition, I don't know what proportion of the overall Cabana group it was, but it'll be a much smaller group. It's going to be harder to show. But to the extent that heart failure is an indication for an ablation and young is an indication for an ablation, I don't think it's necessary for both to be true.
Now, you indicated the limitations we have with our wait list. So, one of the things that I think it's really important to highlight is the fact that, younger people or people with some kind of LV dysfunction that present to your office with atrial fibrillation that is relatively of new onset, going for a strategy only of rate control is probably not acceptable today. So what I would say is that those patients, you try a cardioversion, give them amiodarone, hold them on amiodarone or sotalol until we get them to the ablation. What do you think about that?
Oh, I'd prefer that we shorten the ablation list. To me, our present ablation list is like doing a primary PCI 2 weeks after the patient presents with their infarct.
Well, we're improving. I can tell you that in the last month, we are doing 30 AF ablations a month, somewhere around that. So that's a lot. But remember, if we do a lot of AF ablations, then we don't do the other people, the WPW, the SVT, the VT. So,
well, there'll be some room for another lab or two in the cancer building.
we hope so. So anyways, the fact is that, what I'm trying to get to is that, these patients most of the time, and, we have a couple of patients in here, for example, I'm on service right now. So there's this guy that right now is 65, but, at 50, he presented with persistent atrial fibrillation. Wasn't that symptomatic? LV function was normal. They just gave him a beta blocker. Actually, he presented with tachycardiomyopathy back then. They cardioverted him, and then that was it. No one else saw him until now when he comes back, now with an LV function of 15%. So the point is that, these patients, particularly if you manifest with tachycardiomyopathy, those are the patients that are going to benefit the most from an AF ablation.
I agree. And in that regard, it's important to note that there are several recommendations in the list of new recommendations that say people who have ever had atrial fibrillation need to be reassessed for the possibility that atrial fibrillation of an asymptomatic variety is back with frequencies that depend on the severity of the first episode. But yes, noting that the individual was in atrial fibrillation is a problem.
So just what's your opinion on, you didn't touch on that, but so the ASSERT trial and other trials have shown that there's not a very good temporal relationship between the time of stroke and atrial fibrillation. So what are your thoughts around all that data and that information there?
Well, I mean, it's incontrovertible. I mean, it's very clear that the moment of atrial fibrillation, although a higher moment of risk for stroke, is only slightly higher than any other time when the patient isn't in atrial fibrillation. That's clear. And so the thought process, as you are very well aware, is that we no longer think of something makes atrial fibrillation, which causes stroke, but rather something makes atrial fibrillation, and the something also predisposes to stroke. And the best bet for the something, of course, is an atrial cardiomyopathy.
So do the guidelines provide any recommendations on risk factor management? You know, we're doing some stuff with weight and things like that. Can you give us a
there's a
2-minute update on that?
No, I can't. You remember that first slide I showed, the general approach? On one side, there was anticoagulation. In the middle was treatment of the arrhythmia. The other side is risk factor modification. And it's not just risk factors for atrial fibrillation, but risk factors for all adverse cardiovascular outcomes. For almost all of the risk factors of other adverse cardiovascular outcomes are risk factors for atrial fibrillation and its complications. So a third of the recommendations are about close follow-up, management of weight, atrial fibrillation, clinics, yada, yada, yada. And no way I can summarize them in a few minutes.
So another issue that comes up a lot and that I try to keep telling people, for when you're going to cardiovert a patient, there was this randomized trial that compared, you know, the usual stacking up energy versus a single 360 shock. What is your practice, and what are the guidelines recommendations?
No, the guidelines still say to start, I think it's with 150 biphasic joules. The guidelines still say that. The study that you're reporting came after the guidelines committee began its work, which was almost 2 years ago for that which was produced a year ago. So I would expect that that will be a focus of attention in the next annual update, which will be is in preparation for 2021. My own practice, unless they're a tiny little person, I start with 360 for atrial fibrillation, for the same reason you do.
Agree. Okay, well, thank you very much, Mitch. That was.
Looks like Catherine's got her hand up.
Catherine got her hand up. Oh yeah, sorry, Catherine.
What about the frequency of SCAF? Any comments on that and how you manage them at the moment? Because you may have just a couple, or you could have many an hour.
Yes, Catherine. Most commonly, SCAF is infrequent. In fact, in my experience, I can only recall one person who was having lots and lots of SCAF, and it took her about 2.5 to 3 months before she had an episode over 24 hours. So I think once your SCAF is occurring very frequently, you might well be a different kind of individual who is just on the cusp of declaring themselves as a clinical atrial fibrillation patient.
Okay.
Now, what do we do about them for anticoagulation at the moment? I don't know. At some point, we all get too nervous and anticoagulate them.
Yep.
Yeah, I guess there's a nice other sub-study from a CERT that looked at SCAF progression in patients that also had heart failure. And there's like a 4-fold increase in heart failure hospitalizations and about a 5-fold increase in the progression of to more prolonged atrial fibrillation. So same principle, SCAF begets atrial fibrillation. And by the time that they have a higher burden, it becomes clinical atrial fibrillation.
Agreed.
Which usually manifests with heart failure. Anyways, well, thank you very much. That was a tour de force. We all learned quite a bit, and it's 8:59, so got to go in round. Thanks, Mitch.
Good day.